Really sorry for the delay. I don't know. There is a small technical issue in Zoom because my package is 500, but it's not only allowing 300 only. So now I am doing the YouTube live stream. So I have shared the link. So please join to the class through the Zoom. And if you have any doubt, you can ask me through the WhatsApp, because the students who join through the YouTube, you can't ask questions, no? So then you can ask the doubt through the WhatsApp. So then I can respond to your doubts. Okay. I'm really sorry for the delay. So as I promised you, so your exam got delayed. So you are away from the obs and gynae. So we will do a series of free paper discussion like last time also I did the same. So ultimately we need 90%, more than 90% pass rate. That's it. So today I'm doing the second paper. So maybe my plan is to do at least once a week paper. So then you can keep touch with the obs and gynae. I can keep you reminding the stuff, and you can do well in the exam, right? So that is what I can help you. And of course, probably maybe in 2 weeks time, you can get it within 2 weeks time, you can get my platform. So you will get 24/7 restreaming with the high security. So once you join, you will get restreaming whenever you want. You can watch it. So it is in an organized manner, like topic wise. So you can simply go watch it. So it is there are so many advanced features are there. So we are doing a lot of test drives. So if everything is okay, we can give the 24/7, right? So we are on the security checkup. So that is also another good news for you, right? So now we are going to do the paper. Once the platform is ready, I will let you know. So then we will do the security checkup. Then after that we can use that platform, right? We are going to do the MCQ first, then we will do the SBA. First question is regarding the cesarean section, right? So this is how I'm going to do. So we will also, the students who joined to my previous paper class might know how we are doing the paper class. So we will do the question. So each and every step I will tell you why it is true, why it is false, why we are rejecting this answer, because doing this question is not the target of doing paper class, because you can't expect the same sentence, same question in your exam. So, but what you have to do is you have to identify the principle. So I will teach you the principle. So what is the principle behind this question? So you need to identify the principle. So as I am telling you all the time, so when you are reading the question, so there are a few things you need to understand. First, you need to read the question. Second, you need to identify what is the information and what are the important points you need to highlight in that question. Third one, you have to utilize your background knowledge. And fourth one, you need to think rationally. So these are the steps. Then only you have to answer your question. So read the question, identify the core problem, utilize your background knowledge, rationally think, and answer the question. This is what you have to do in the exams, right? So then whatever the question comes, whether it's easy, whether it's hard, you won't feel as it's a hard paper, because last time you can ask your seniors. Most of the seniors told, so paper is easy, it's manageable. Actually, it's not easy. If you see the previous years also same paper, but my students could understand the paper. What is it? So then they could do it, right? So that's the reason. So far in obs and gynae history, it was 30% pass rate. There were a lot of teachers, a lot of students, a lot of exams, but only 30% of students got through. But since I came to the field, my students' pass rate is 90%. Even last time also, out of 350 students who came to my class from the exam batch, more than 320 got through the exams. So it means it is not the problem with the students. So it's problem with me. If I can't make you to understand, if I can't make you to give this obs and gynae subject in a way you can understand, you can't pass the exam. So what I'm doing is I'm just making my students to understand. So then they can pass. So that is what I'm going to do for this batch as well. So we will do the same in following batches as well, right? So this time also, last week, a couple of weeks ago, we had a part C exams, right? So the Viva emergency. So around 10 students called me and said, the examiner was asking who is your teacher, because the way they were answering like a postgraduates, they told that you are answering like a postgraduate, because not only the subject, also we are studying how to answer, how to handle the examiner. So these are art. Exam is an art, right? So when you come to the Viva, when you come to the emergency, I will teach you how to answer, how to see the examiner, how to keep the eye contact, everything. Small thing you need to concentrate. So even when you are doing the MCQ also, the same thing. You have to concentrate small words, because those words will change your answer. So you can simply make a mistake by missing a small word. So then I'm going to guide you how to interpret the question, how to rationally thinking. So in theory class and topic-wise revision, I have given the background knowledge to you. Now you have a good background knowledge. So hopefully, if we have when we have the Restream platform, if it is really 24/7 access, so when you are doing question, if you have doubt, you can go and watch it. So then you will be the best students in the world. Definitely, you will answer like postgraduate. So I'm really happy when my students are calling and telling, so you are answering like a postgraduate. Who is your General Ops teacher? So that is what you have to give, not the money. That is what you have to give to us, to me. So I have given the knowledge. You are giving that word to me from the examiners. So really happy moment when they are telling. So I'm believing you also will do the same. Right, great. So first question regarding the cesarean section. So we know what is cesarean section. Cesarean section is a mode of delivery where the vaginal delivery is not possible, or when we need a urgent delivery, when the vaginal delivery is not suitable because the cervix is not dilated, but you can't wait until the dilatation because baby is having some kind of distress, mother is having some kind of distress. So in that case, we are going to do the cesarean section. So it's another route to deliver the baby, right? So there are indications for the cesarean section. There are type of cesarean section, right? Type 1, so category 1 cesarean section. It means from the decision making, within 30 minutes, you need to take the baby out. Type 2 cesarean section. This is cesarean section. From the decision making to 70 minutes time, you need to take the baby out. So say, for example, type 1 cesarean section, category 1 cesarean section means, so if it is a uterine rupture, placental abruption, placenta separated, so in that case, you can't wait. So you need to take the baby as early as possible, otherwise baby will die, mother will die. So we can categorize the cesarean section into category 1, category 2, category 3, category 4. Right? So type of cesarean section, lower segment cesarean section, upper segment cesarean section. So we are cutting the lower segment, we are cutting the upper segment. So that is called type of cesarean section. And there are indications why we are doing the cesarean section. Fetal distress, maternal distress, right? So previous cesarean section, cephalopelvic disproportion. Baby couldn't come through the birth canal. So then what you have to do, you have to go through the abdominal way, right? So like that, there are things you need to know. Right. So here they're asking about few things regarding the cesarean section. Right. So what are the problem with the cesarean section? There are complications, anesthetic complications, high spinal, right? So surgical related complication like postpartum hemorrhage. You might damage the bowel. You might damage the bladder. You might damage the ureter. You might damage the blood vessels. So internal organ damage, bleeding, right? So maybe infection. Right? So infection, risk of DVT. And second thing, so if you do the cesarean section, next time when she become pregnant, her uterus might get rupture, risk of uterine rupture. So you may have to do elective cesarean section. If it is a cesarean section, placenta might come, might implant in the lower part. How do you call that? That is called placenta previa. So cesarean section is a risk factor for placenta previa. Not only placenta previa, when there is a scar area, this placenta might go through the scar tissue. So how do you call that? How do we call when the placenta going through the scar tissue into the myometrium? How do we call that? We call morbidly adherent placenta. Morbidly adherent placenta. Do you understand? So I like you all have to actively participate. So I'm expecting answers from you, right? So otherwise it is going to be a lectures. I don't like these lectures kind of classes. So it should be an interactive class. Okay. So please answer when I'm asking question. Right. Thank you. So morbidly adherent placenta, risk is high, right? So as I told you, so when you do cesarean section, next pregnancy, uterus might get rupture. The rupture risk is very dependent on some condition, like, so type of cesarean section. If you cut the uterus in the lower segment, that lower segment is least distended in next pregnancy. But upper segment is highly distended in next pregnancy. So for example, if you cut the uterus in the upper part, when the baby is growing, the upper part will grow up to cipisternum from the pubis. So distension is higher. So risk of rupture in consequent pregnancy is high. Do you understand? Then upper segment has a lot of muscle fibers. So in consequent pregnancy, these muscle fibers are the one involving with the uterine contraction. So damaged muscle fibers, when it is contract, it might easily rupture. So upper segment cesarean sections are risk of rupture. So risk of rupture for the upper segment is a bit high. But if it is a lower segment, actually least distended part, and this lower segment has mostly fibrous tissue, not the muscle fibers are less. So it will not actively participate in the uterine contraction. So risk of rupture is less. So for the lower segment cesarean section, risk of rupture is around 0.5%, 1 in 200. If 200 mothers go for a vaginal birth after cesarean section, one mother might have uterine rupture. Rest of the mothers will not have uterine rupture. But if it is an upper segment cesarean section, uterine rupture risk is a bit high. Do you understand what I'm telling? Yes, great. So now we will go to the, so this is kind of a small background information about the cesarean section. We'll go to the statement. Previous upper segment cesarean section is an absolute contraindication for VBAC. What do you think? True or false? Yeah, it's obviously it's true. Reason is, as I told you, if it is an upper segment cesarean section, risk of rupture is bit high. Upper segment cesarean section, risk of rupture is bit high. So as it is, as this risk is bit high, right? So what will happen? We don't allow them to go for a vaginal delivery. We don't allow them to go for a vaginal delivery. So it is upper segment cesarean section is an absolute contraindication for the VBAC. So second one, past 3 cesarean section is an indication for upper segment cesarean section. If somebody undergo 3 cesarean section, lower segment cesarean section, 3 times if you cut the lower segment, when you go for 4th cesarean section, it is an indication for upper segment cesarean section. True or false?
False.
It's false. Very good. It's false. Actually, you don't need to do the cesarean section for previous lower segment cesarean section. Because every time we are cutting over the scar, we are cutting over the lower segment. It is not a problem. But there are indications for the upper segment cesarean section. So this is what we are learning in the paper class. Because just telling the answer false, it's not important. Now I am going to tell you what are the indications for the upper segment cesarean section. Now you are learning a new thing related to this statement. Do you understand? This is how you need to study. So even though you are studying like even though you are studying the answers, you need to know the addition. So next time they might ask, this is an indication for lower segment cesarean, upper segment cesarean section. So then you know. Do you understand what I'm telling? Okay, now tell me what are the indications for the upper segment cesarean section. One is lower segment fibroid. If it is a fibroid in the lower part, you can't cut it. You may have to go for upper segment cesarean section. Right? Morbidly adherent placenta. Then you may have to go for a upper segment. So lower lying cesarean section actually, lower lying placenta previa, it's not an absolute indication for the upper segment. If it is a placenta previa, you can cut the lower segment, you can cut the placenta, you can go through the placenta and take the baby out. But if it is a morbidly adherent placenta, you can't do that because we know once we damage the placenta, as it is a morbidly adherent, it will not come out. So then she will bleed a lot. So if it is a morbidly adherent, we are cutting upper segment. But placenta previa, it's not an absolute indication, right? So uterine anomaly, severe adhesions in the lower part, then you may have to cut in the upper segment. These are the indication for the upper segment cesarean section. Do you all understand? Yeah, emergency cesarean section, yes. So it is a very urgent one, because when we are doing the lower segment cesarean section, what we have to do is we have to cut the peritoneum, and we need to push the bladder down before we do the surgery, right? So before we do the surgery, we need to push the bladder down. So it takes time. Otherwise, what will happen, because the lower segment is at the level of bladder. So when you cut the lower segment, you might damage the bladder. So that's why what we do with the peritoneum, we are pushing the bladder down, then only we are cutting the uterus. So it takes some time. So in case of very urgent delivery, like cord prolapse, severe fetal distress, if you don't have time to push the bladder down, there are some bladder adhesions, so you couldn't release the adhesion very fast. In that case, we don't waste the time by doing this, pushing the bladder down. Rather than spending the time, we are just cutting the upper segment and take the baby out. Right? You will understand what I'm telling. Those are the indication for the upper segment cesarean section. So past 3 cesarean section is an indication for the upper segment cesarean section. Obviously, no, you don't need to do the cesarean section for the upper segment cesarean section for the lower previous past cesarean section. Sorry. Elective lower segment cesarean section is performed at 39 weeks of gestation. True or false? Yeah, that's true, right? So all the elective section you have to do at 39 weeks. Why we don't do beyond 39 weeks? Because beyond 39 weeks, the intrauterine death risk is a bit high. Before 39 weeks, if you do cesarean section, what will happen? Baby might have respiratory distress, right? Maybe might have respiratory distress, right? Transient apneic attack, because baby is not ready to come out. You are cutting and taking the baby out. So when the baby is not ready, when you take out, so just you are preparing for the ERPM exam, you are not ready for the marriage. If your father suddenly arranged marriage and you got married, then what will happen? You will develop distress, obviously. Agree? Because you are not prepared. But the thing is, even after you passed out, after you complete your internship, at 35 years, still you are not marrying. That is also risk, isn't it? So you can't wait later, you can't do early. So it should be in the correct time. Like that, for the cesarean section, what is the correct time? Is 39. Do you understand? It is 39. So what you have to do, you have to clear your internship. You are clear your ERPM on time, right? So don't fail the exam, pass the exam this time, and get married on time. Otherwise, you will develop distress or IUD. Do you understand? If you marry now, it's distress. If you are delaying, then risk of IUD is high. So you have to do it on time. Right. So, okay. So elective cesarean section will be done at 39 weeks. Yeah, that's true. Morbidly adherent placenta risk is increase in subsequent pregnancy after cesarean section. What do you think? I told. Yeah. If it is a cesarean section, the scar tissue is weak, then placenta might go in. Yeah, that's true. 4 hours fasting for clear fluid necessary before cesarean section. What do you think? 4 hours fasting for 4 hours fasting for clear fluid is necessary. Yeah, true or false?
True. Solid for 6 hours, fluid 4 hours.
No, clear fluid is 2 hours. Okay. Solid food 6 hours, I agree. That is correct, right? So we need minimum of 6 hours fasting for the solid food. But for the clear fluid, 2 hours is enough. Because gastric emptying for the clear fluid is just 2 hours. So you can ask the patient to drink water just 2 hours before the surgery, right? So then it's false, not the fast 4 hours. So answer for question number 1, true, false, true, true, false. Question number 2, following statements are true or false regarding cervical cancer. Cervical CA. HSV is a causative agent. No, it's false.
HSV.
Yes. HSV means human herpes simplex virus. HPV means human papilloma virus. So 99.7% of cervical CA is due to human papilloma virus. 99.7% of cervical CA is due to human papilloma virus. Understood? So almost all cervical CA is due to human papilloma virus. Almost all cervical CA is due to human papilloma virus. So that's why if you can prevent the human papilloma viral infection, you can prevent the cervical CA. This human papilloma viral infection is a STI, sexually transmitted infection. It's a viral infection. So you can prevent it. Safe sexual practice. Right? So you can avoid the multiple sexual partner, high-risk sexual partner. You can vaccinate against the virus. So then human HPV will not infect you. You will not develop this cervical CA. Do you understand? So HSV is a causative agent. False. It is HPV. Adenocarcinoma is the most commonest type. False. So there are two types of carcinoma. One is adeno, another one is squamous. Right? Squamous carcinoma, squamous cell carcinoma, stratified squamous carcinoma is the most common cancer which affects the cervical CA. Roughly 80%. Right? So adenocarcinoma is not a common one. But when you see the prognosis, what do you think about the prognosis? Now I am telling a new fact. Right? So commonest one is the question. I am telling the prognosis. Next time you might get question on prognosis. So you need to write these things. So when we are doing the paper class, you have to write this one. So this one is squamous is common prognosis. Which one is first? Which one is having good prognosis? Adeno or squamous?
Adenocarcinoma, good prognosis.
No, squamous is the good prognosis. Right? Squamous is the good prognosis. Adeno is the worse prognosis than the squamous, right? Okay, great. So adenocarcinoma is the commonest type. False. It's squamous. Chemotherapy is the main mode of treatment. What is the main mode of treatment for the cervical CA?
Radiotherapy?
Yeah. Actually, when you see the management of cervical CA, right? Radiotherapy and surgical management is equally effective. Radiotherapy and surgical management is equally effective. Effectiveness wise, both are same. Right? So this chemotherapy is actually it's reserved for advanced cancers like stage 3, stage 4. When it is disseminated, you need to give chemo. The chemo is not the mainstay of treatment for the cervical CA. Cervical CA, radiotherapy and surgery is equally effective, but the side effect profile will vary depending on the stage of the cancer, right? So side effect profile. Say for example, just what I'm meaning. So I don't know whether you understand. I'm explaining. Say for example, if it is stage 1A or 1B, whatever, stage 1 cancer. So as we discussed now, it is both are equally effective, but when you give the radiotherapy to the stage 1 cancer, the side effect due to radiotherapy is a bit high, like premature organ failure, vaginal dryness, vaginal narrowing, dyspareunia, sexual dysfunction, right? So bowel dysfunction, like there are a lot of side effects due to radiotherapy. But doing surgery and removal of the uterus is not having much side effect when compared to radiotherapy. So both are equally effective, but side effect profile is more to the radiotherapy than the surgery. So the preferable mode of management is surgery for early cancers. But when it is an advanced cancer like 2B or more, when the cervical CA 2B or more, it means parametrial involvement or lateral pelvic wall involvement. So when it is involved to the parametrium 2B or more, if you are going to do the surgical management, what you have to do, you have to resect entire parametrium. You have to resect the pelvic wall and the organs. So what will happen? The surgical resection is more. The damage to the ureter, damage to the bladder, damage to the bowel, damage to the organs, right? Surgical recovery, it's very less. So complication is very high for the surgery when it is extensive. But surgical, radiotherapy complication is less than the surgical complication when it is advanced. So is the chemoradiation or radiotherapy same? No. Chemoradiation is mixture of both chemical chemotherapy and radiotherapy. So when it is early stage of cancer, radiotherapy surgery is the mainstay of treatment. When it is a late stage, it means 2B or more, radiotherapy is the mainstay of treatment. But when it is 3 or 4 disseminated one, so say for example, malignancy is in the brain. Can you give the radiotherapy to the brain? It may disseminate to the brain, lungs, liver. So can you do the radiation to the entire body? No, you can't do that. So in that case, what we do, we give the chemotherapy for the disseminated malignancy. Do you understand? So this is the principle, how we are treating the patient. So here they are mentioning chemoradiotherapy is the main mode of treatment. No, chemoradiation is not a main mode of treatment, right? So it's false. HPV vaccination is a secondary prevention. True or false? Yeah. Okay. So what is if it is false, then what kind of prevention? HPV vaccination is a primary. Very good. So cervical CA can be prevented in different way: primary, secondary, tertiary. What is primary? Primary means before the HPV infection occur, we do some intervention to reduce the HPV infection. Second one is secondary prevention, means after the infection, before it's become malignancy, you are doing some intervention. Right? So the primary preventions are like HPV vaccination, safe sexual practice, sexual education, right? So avoid the multiple sexual partner, usage of condom. So you are preventing the HPV infection. So then without infection, obviously you won't get the cervical CA. That is a primary prevention. Secondary prevention, of course, HPV infection occur now pre-malignant lesion. Low LCIL, low-grade intraepithelial lesion, squamous lesion, LCIL or HCIL. So we are screening for the pre-malignant lesion. If it is a pre-malignant lesion, before it become malignant, we are removing the lesion. Right? So your pap smear, colposcopy, right? So liquid-based cytology. So those kind of screening system are secondary prevention. Do you understand? So the secondary prevention after the infection. So HPV vaccination is secondary prevention. False. That is a primary prevention. Right. Radical hysterectomy is the surgical option for stage 1A cancer. Radical hysterectomy is a treatment modality for the stage 1A cancer. What is 1A cancer? 1A mean, so 1 mean cervical cancer confined to the cervix. It's not beyond the cervix. It is confined to the cervix. So this confined to the cervix lesion can be divided into two. One is 1A and 1B. 1A is microscopic lesion. 1B is macroscopic lesion. Right? So microscopic lesion means less than 7 millimeter depth, width, and less than 5 millimeter depth. So the lesion is less than 7 into 5 millimeter. Do you understand? So it's small lesion. If it is more than 7 millimeter, that is categorized as macroscopic lesion, 1B. So if it is 1A, obviously we know this is a microscopic lesion, small one. So if you want to cut your nail, are you going to cut the nail or are you going to cut the finger? What you are doing? Are you cutting the finger every time when the nail is growing? No. What we do, we are just cutting the nail. That's it. Do you understand what I'm telling? So you can't ablate. Malignant lesions can't be ablated because you have to make sure you have excised out entire lesion. So how do you know you have excised out entire lesion? After you do the excision, you have to see on the microscope whether you have excited everything. So there are some free margins. So always ablation is not possible. You need to go for a resection. So what kind of resection we are doing? Cone biopsy. Right? So you can go for a cone biopsy or you can go for a tachylectomy. What do you understand by tachylectomy? What is tachylectomy? Tachylectomy?
For fertility.
Yeah. Whatever it is, fertility issue, whatever, it is removal of cervix. It's a trachelectomy. So if it is an early stage of cancer, you can remove the cervix only, or you can remove part of cervix with involvement of the malignancy. You don't need to take the uterus out. So if it is 1A, you don't need to take the uterus. We have to do the cone biopsy or trachelectomy. But if it is more than 1A, 1B or 2A, it means it is a macroscopic lesion. So the cervix is involved. There might be some metastasis into the vagina. So removal of cervix and uterus is not enough. Also, you have to remove the vagina as well. So then what we do the radical hysterectomy. What do you understand by radical hysterectomy? We remove the uterus, we remove the part of vagina, we remove part of uterosacral ligament, we remove part of cardinal ligament. So we are removing entire structure right around the cervix, because there might be some small metastasis, micrometastasis. Do you understand? So it is false. So answer for question number 2, false. Right. Question number 3, whether it's true or false, predisposing factors for the postpartum hemorrhage. It's a common question. So with the experience, these are some past paper question. Actually, with the experience, last exam, they didn't ask like this scholarship type questions, grade 5 type questions, following are risk factors, those kind of questions they didn't ask last time, right? So just memorizing the stuff is not going to be beneficial for you, because last time they have asked questions like, what is the pathophysiological explanation? What is the physiological background for this kind of understanding? Without knowing the stuff, you can't answer for those questions. Do you understand? So you have to prepare the exam like this. These days, exams are like that. Right? So you need to understand, you need to go to the depth, pathophysiological explanation. Just remembering it's not going to be beneficial for your exam as well as your clinical practice, right? So of course you need to know this one definitely. What are the risk factors or predisposing factors for the postpartum hemorrhage? So you don't need to memorize anything. Just think about that. So what are the causes for the PPH? Maybe 40. Tone, trauma, tissue, thrombin. What is tone? Uterine hypotonia. It means uterus failed to contract. It's relaxed. Why uterus failed to contract? Because uterus overdistended. Because uterus is working for a long time. Say, you can say now. What are the risk factors? Like overdistension, multiple pregnancy, polyhydramnios, macrosomia, fibroid complicating pregnancy. It's failed to contract. Right? Or maybe overload, overworkload, like prolonged labor, obstructed labor, arrest, primary arrest, secondary arrest, induction of labor. You are making the uterus to work hard. Uterus got tired, couldn't contract. Right? So perineal tear, so trauma. So what other condition can lead to perineal tear? Instrumental delivery, large baby. Do you understand? Large baby. Some malposition, occipito-posterior, face presentation, malposition, because that is not the correct position. So when the baby is coming in a wrong way, it might damage your birth canal, right? So tissue, retained product, placenta, retained membrane, right? So some condition might lead to alter your coagulation, like DIC, obstructive cholestasis, thrombocytopenia. Do you understand? So if you know the causes, you can predict the PPH. So always in obstetrics, the most important part is prediction of the complication, because obstetric is a physiological one. Anytime it might convert to pathology, so you have to predict the complication by identifying the risk factors. So now they're asking about the postpartum hemorrhage risk factors. Cesarean section, of course, because you are damaging the cells. And uterus is, if it is a normal vaginal delivery, right, uterus has oxytocin receptor. The uterus is responding to the oxytocin. Uterus is contracting. So after the delivery, what will happen? Uterus normally contracts, because already uterus contractile process started. Agree? But in cesarean section, uterus is not contracting. It's in a relaxed mood. Suddenly you cut and you took the baby out. There is no oxytocin receptors. So then uterus might fail to contract after the cesarean section. So PPH risk is a bit high with a cesarean section. So cesarean section, yeah, it's risk factor. Precipitated labor, yeah, of course, because once the baby comes quickly, whatever the things happen very fast, then complication also high. So precipitated labor, true. Oligohydramnios, actually oligohydramniosis will not cause overdistension. Polyhydramnios, yeah, it will cause. So oligohydramnios false. Prolonged labor, what do you think about prolonged labor? Yeah, of course, uterine muscles got tired. Retained placenta, of course, because the tissue will prevent the uterine contraction as well as it will lead to bleed. Yeah, that's true. So answer for question number 3, true, false, true. Right. Question number 4, drugs that can be used in heavy menstrual bleeding. So the drugs which can use in heavy menstrual bleeding, we can easily categorize and keep it in your mind in a nice way. I'm just telling, non-hormonal treatment, then hormonal treatment, right? Non-hormonal treatment, hormonal treatment, then surgical treatment. Surgical treatment can be further classified into 2, minimally invasive and invasive procedure. So what is precipitated bleeding? Actually, not the precipitated bleeding, precipitated labor. It means within 1 hour, baby delivered. Sudden, quickly baby delivered. So usually it takes 4 hours, 5 hours, 6 hours. No, so then uterus will train to contract. But if the baby delivered very fast, then uterus might fail to contract. It's not get trained. So that's the reason, right? Okay. So your heavy menstrual bleeding management can be classified into non-hormonal, hormonal, surgical. Surgical can further classified into minimally invasive and surgical procedure. Non-hormonal one, of course, we can treat them with tranexamic acid, and if they have pain, of course, mefenamic acid. Then hormonal one, there are so many hormonal treatment. Like one is progesterone. Progesterone can be administered in a different way, like LNGIUS, oral progesterone, injectable projection, DMPA, so progesterone. Right? So OCP. Right? OCP. You can give OCP. Right? So if it is a fibroid, you can give ulipristate acetate. So there are hormonal treatment. Then surgical treatment, minimally invasive and surgery. So minimally invasive treatments are endometrial resection, endometrial ablation. Right? Invasive surgery or definitive surgery, hysterectomy. Hysterectomy can be different type of hysterectomy. Abdomen, total abdominal hysterectomy, total laparoscopy hysterectomy, vaginal hysterectomy. Do you understand? So you have to have some idea like a flow chart. Always you need to have a flow chart. When they're asking the question, you have to think, is it possible? Is it possible? Right. So now the question is drugs that can be used in heavy menstrual bleeding, bromocriptine, false. Bromocriptine, we are not using, that is bromocriptine we are using for the hyperprolactinemia, right? So it's false. Yes. Yeah. Sorry. Yeah. Okay. So tranexamic acid, of course, tranexamic acid will reduce the menstrual bleeding by 60%, almost 58%. If it is OCP, it will reduce the bleeding by 50%. Mefenamic acid will reduce the bleeding by 25%. LNGIUS reduce the bleeding by 90%. Right? So you need to know, right? So tranexamic acid, yeah, it's true. Aspirin, aspirin is antiplatelet. We are not using for menstrual bleeding reduction. Tamoxifen, no, it's false. COCP, yes, it will reduce by 50%. It's true. So answer for question number 4, true, false, true, false, false, true. Question number 5, which of the following are true? Complication of vaginal hysterectomy, right? So always you need to keep in your mind when they're asking about the surgical complication, you have to categorize the complication into this. So now you have to understand how I'm making you to keep the stuff in your mind without complicated, right? So you have to have that idea. So does mefenamic acid reduce the bleeding? Yes, it will reduce by 25%. But we are not using the mefenamic acid for bleeding reduction purpose alone. because that is mainly used for the pain reduction, right? So, but mefenamic acid also will reduce the bleeding by 25%, right? So when you are talking about the complication, always you have to keep that in your mind, how you are categorizing the complication risk. One is surgical related complication, second one is anesthetic related complication, right? Then surgical related complication you can classify it as immediate complication. Or so during the surgery or during the surgery time you can have the complication. Then early complication. So in postpartum, so post-operative period, you can have complication. Late complication, like in a week time, you can have complication. Then long-term complications, maybe after 6 months, 1 year, 2 years, 10 years, 20 years, you can have some complication. Do you understand? So you can classify the complication like this. So anesthesia-related complication, of course, we are doing the vaginal hysterectomy and the spinal anesthesia, so patient can develop high spinal, right? Meningitis, spinal headache. So those are the anesthesia complications. So during the surgery, you can damage the organ. So what is the neighbor, very close neighbor to the uterus? Who is the neighbor to the uterus? Bladder, rectum. Yes, correct. So you can damage the bladder. You can damage the rectum, right? Rectal damage, bladder damage, right? So those are maybe you might damage some vessels like uterine artery slipping uterine artery, might bleed, right? Walt hematoma. So these are during the surgery. Some are early complication like bleeding or bleeding from the surgical site, Walt hematoma, right? So slipping of the stitch might lead to bleed inside the abdomen, intra-abdominal bleeding. Right. So then some late complication, like after week time, infection. It takes some time for the infection. So immediately after the surgery, you won't get the infection. Even the organism inoculated, it takes time to cause infection. Incubation period. Right. So fistula formation. Right. Rectovaginal fistula. Urethrovaginal fistula. Urethrovaginal fistula. Vesicovaginal fistula. Fistula formation. It takes time, maybe 1 week, 2 weeks time. Yes, urinary leakage. Stress urge urinary incontinence because you are manipulating the bladder. It can cause urge urinary incontinence. So these are the late complications, long-term complications. Yeah, what are the long-term complications? Your vault might get weakened, vault prolapse, stress urinary incontinence. Those are the long-term complications. Now they're asking, they didn't ask what kind of complication, they are just asking complication of hysterectomy. Bladder damage, true. Damage to the internal iliac artery. Actually, internal iliac artery is in the lateral pelvic wall. You are doing the surgery in the vagina. So the chances to damage the internal iliac artery is less when you are doing the vaginal hysterectomy. But if you are doing abdominal hysterectomy, you are cutting through the upper abdomen, you are going into the pelvic cavity, you have access to the lateral pelvic wall, you can damage the internal iliac artery. Internal iliac artery risk is high when it is an abdominal hysterectomy, not to the vaginal hysterectomy, right? And paralytic ileus. Why? What is the most common cause for the paralytic ileus? When you are handling the bowel. So if you are cutting the vagina, if you are taking the uterus through the vagina, you are not handling the bowel. So paralytic ileus risk is less. But if you are cutting the tummy, so here the bowel is there, then you push the bowel, put the towel and pack the vagina, abdominal cavity with the towel to hide the bowel from the surgical site, then only you are operating. So you are handling the bowel more. So abdominal hysterectomy has high risk of paralytic ileus, not the vaginal hysterectomy. So it's false. Rectal injury, yeah, of course it can. And wall prolapse, yeah, that is a long-term complication. So answer for question number 5, true, false, false, true, true. Question number 6, following are true or false regarding the prerequisite for the vacuum delivery. So what is prerequisite vacuum delivery? You need to know when you are doing the vaginal, so instrumental delivery, you need to know there are some prerequisiting. Does general anesthesia increase risk of paralytic ileus? Yeah, that can. But vaginal hysterectomy we don't do under general anesthesia. We are doing under spinal anesthesia. Okay, right. So prerequisite for the instrumental delivery. If you are going for an instrumental delivery, what are the things you need to check? Prerequisite for the instrumental delivery, right? So prerequisite for the instrumental delivery. So first, it should be fully dilated. Second, membrane should rupture. Third, there should not be any evidence of cephalopelvic disproportion. Why? If it is a cephalopelvic disproportion, it means your passage is not enough to allow the passenger to come. So if this passage is not enough, then how can you pull the baby? Then it will damage the mother as well as the baby. It is contraindicated for the vaginal delivery. So there should not be any evidence of cephalopelvic disproportion. You should be able to identify the position and presentation of the baby. So for example, if you don't know how to identify whether it's face presentation or cephalic presentation, vertex presentation, right? So if the baby is in face presentation, if you put the vacuum over the face, what will happen? It will damage the baby's face. Do you understand what I'm telling? Do you understand what I'm telling? So face presentation is contraindicated for the vacuum delivery. So you should be able to identify the face presentation. If it is occipital transverse position, you can't put forceps because it will damage the baby's eyeball as well as the face. So you should be able to identify the position of the baby, presentation of the baby. If you are not sure about the position, if you are not sure about the presentation, you can't put the vacuum. Right? Oh, you can't put the forceps. And third one, the baby's station should be at or below the ischial spine. Baby's head should be at or below the ischial spine. Right? If it is above the ischial spine, we categorize that as high cavity. Above the ischial spine means it is high cavity. High cavity forceps or vacuum is not recommended. High cavity vacuum or forceps is not recommended. So it should be below the ischial spine level or at or below the ischial spine level. At or below the ischial spine level. Do you all understand? At or below the ischial spine level. Do you all understand? Great. So, now the question is, following are true or false regarding prerequisites for the vacuum delivery. Membrane should be ruptured. True or false? Yeah, membrane should rupture. That's true. Cervical dilatation is at least 9 centimeter. False.
10 centimeter.
It should be 10 centimeter, fully dilated, right? Not 9 centimeter. You can't put vacuum or forceps for 9 centimeter. It should be 10 centimeter. It's false. Fetal heart rate should be normal. No, it's false, right? So one of the indication for the instrumental delivery is fetal heart rate abnormality. If the baby is doing good, why you want to put the instrument and take the baby out? Let the baby to come spontaneously. Do you understand? So if the baby is having problem, only we are putting the vacuum or forceps. So that is not the prerequisite. It's false. Bladder should be emptied. True or false? True. True. If the bladder full, what will happen? The bladder will push the baby's head upward. So then you can't take the baby's head through the vagina. So bladder should be emptied. So before you put the vacuum, empty the bladder. Then only you have to put the vacuum of forceps. So bladder should be empty. True. Fetal position should be able to identify.
True.
True. I told you, right? It's true. So answer for question number 6, true, false, false, true, true. Now you all understand, when you have a background knowledge, how easy it is. Right? So if you have a good background knowledge, if you know how to identify the core problem and understand the question, then it's easy, nothing. So you can get more than all 5 answers correct. Right? So don't worry, before once they announce the exam, I will guide you how to mark, how many MCQ you need, how many true or false you need to mark, how to mark. So those kind of things I will teach you. Right? Okay. So question number 7. So do we empty the bladder in every delivery? Yeah, of course. But what we are doing, we are asking the patient to empty the bladder. Patient can pass the urine and she can strain, then baby will come out. You don't need to put the catheter and empty the bladder. Right? complication of diabetes in pregnancy. So here there is a small tricky point, right? Sometimes you might get complication of gestational diabetes. Sometimes you might get question like complication of chronic diabetes. Here they didn't mention what kind of diabetes. They just asked complication of diabetes in pregnancy. So diabetes in pregnancy could be either one, either GDM or chronic diabetes. Do you understand? So very careful when you read the question, right? So that is what I'm telling. Each and every word is very important in question. So knowing the stuff is not enough. You should know how to do the exam, right? So complication of diabetes in pregnancy, whatever the diabetes, whether it's GDM, whether it's chronic, whether it's MODY, whatever, right? But sometimes they might specifically ask what a complication of diabetes in pregnancy which occurred at 30 weeks of period of gestation. So what do you understand by this? GDM. They are asking indirectly complication of GDM. Do you understand what I'm telling? So always you have to use your brain, right? So otherwise it will atrophy, disuse atrophy, right? So complication of diabetes in pregnancy, ventricular septal defect, right? So this structural abnormality, right? Structural abnormalities are complication of chronic diabetes. Why I am telling that? Because when the baby is formed, when the organogenesis occurs, if the mother has hyperglycemia, means the first 3 months, if mother has hyperglycemia, that can affect the organogenesis. Do you all understand? That can affect the organogenesis. So if a mother has diabetes in first trimester, it means when she becomes pregnant, she is diabetes. It means it's chronic diabetes. So they're asking chronic diabetes. So what are the chronic diabetes complications? Right? Cardiac anomaly, ventricular septal defect. Yeah, cardiac anomaly can occur. Right? Sacral agenesis or caudal agenesis. Neural tube defect. That's why for the chronic diabetes mothers, we are giving 5 milligram folic acid because to prevent the neural tube defect. Right? So neural tube defect can occur. So these are complications of anyhow, ventricular septal defect can occur in diabetes. That's true. Complication of diabetes in pregnancy, neonatal hypoglycemia. What do you think? True or false? Is it a complication? Yeah, of course, it's a complication. Why it is? Because when the mother is hyperglycemic, whether chronic or GDM, doesn't matter. When the mother is hyperglycemic, the glucose will transfer to the baby. So baby also will be hyperglycemic. Agree? Baby also will be hyperglycemic. When the baby is hyperglycemic, actually, the fetal pancreas is normal. The problem is maternal pancreas. That's why mother is diabetes. But fetal pancreas is normal. When the baby's pancreas is normal, when the fetal glucose level goes up, what will happen? The pancreas will secrete more and more insulin. So, the baby who is delivering to a diabetic mother will have more secreted insulin in their blood than non-diabetic mother's baby. Agree? Right? Agree? Yeah. So, now say for example, I'm a diabetic mother. Janani is a non-diabetic mother. So, obviously, my baby will have hyperglycemia. So, my baby's pancreas is secreting more and more insulin. So, my baby's blood will have more insulin in their blood. But Janani's baby's blood will have less amount of insulin. Now, what is happening? We both are delivering the baby. Once we deliver the baby, what we do, we are clamping the umbilical cord. Right? We are, sorry, hypercalcemia, no? Oh, right. Okay. Right. Okay. Anyhow, I'll teach you the glycemia, then I'll tell about the hypercalcemia. So that we are clamping the cord. Once we clamp the cord, what will happen? The glucose supply to the baby will cut down. Once the glucose supply cut down, what will happen? My baby has more insulin, so it will bring down the blood sugar level. So neonate will develop hypoglycemia. So hypoglycemia can occur. Not only hypoglycemia, these diabetic mothers' babies will have deficiencies in most of the micronutrition like magnesium, calcium, right? So baby will develop hypocalcemia, hypomagnesemia, all kind of complication. That is true. IgGR, what do you think? Diabetes can cause IgGR. Chronic diabetes can cause IgGR. GDM will cause macrosomia. But chronic diabetes can cause IgGR. Why? Because chronic diabetes will cause microvascular complication, vasculopathy. So blood supply to the baby will affect, then baby finally will develop IgGR. Yeah, that's true. Neonatal jaundice, yes, because in diabetes, what will happen? Baby's size is larger, so relative hypoxia, which lead excessive production of RBC. So these babies are kind of polycythemic. So because of the polycythemia, after the delivery, all fetal RBC will destroy and adult RBC will replace. So when the baby has a high amount of fetal RBC, the destruction will be high. So bilirubin level will be high. That will lead neonatal hypoglycemia. That's true. Stillbirth, yeah. One of the reasons we are delivering the baby for diabetic mothers at 38 weeks because unexplained fetal death. It's high with diabetes. There are so many reasons. One is it can cause cardiomyopathy. It can cause thrombus formation. It can cause acidosis. So there are so many reasons, but baby might die. Yeah, that's true. So answer for question number 7, 2. Right. Question number 8. Causes of excessive vomiting at 10 weeks of gestation include. So excessive vomiting can be due to excess amount of HCG. That is one. Second reason, any kind of infection, especially urinary tract infection, or maybe like bowel infection, like maybe a gastroenteritis, gastritis, or cholangitis, or gallstone, whatever the condition which is involving with the bowel can cause excessive vomiting. Right? And hepatitis, liver involvement, can cause vomiting. Right? Okay. Now here they are asking, excessive vomiting at 10 weeks gestation, miscarriage. Actually, if it is a miscarriage, this pregnancy is not good. Failing pregnancy. If it is a failing pregnancy, what will happen to the amount of HCG production? What will happen to the amount? It's less. So if it is less, yeah, very good. If it is a less HCG production, what will happen to the vomiting? It's less. It can't be excess. Yeah, it can't be excess. It's false. A urinary tract infection, I told you, urinary tract infection can exacerbate the vomiting. That's true. Gestational trophoblastic disease. What do you think? Gestational trophoblastic disease.
High HCG, excessive vomiting.
Very good. High HCG, which lead excessive vomiting. That's true. Infective hepatitis, yes, I told you. Multiple fibroid, no, it's false. Right? It's false. Right. So answer for question number 8, false. 2, false. Question number 9. Following are true or false regarding the postpartum intrauterine device, PPIUCD. What is PPIUCD? PPIUCD is inserting the intrauterine copper device immediately after the delivery. Right? Earlier, what we do is we used to insert the IUCD after 6 weeks of delivery. Now we are introducing this PPIUCD program. We are inserting the IUCD immediately after the delivery. So what are the instances we can insert this PPIUCD? One is while we are doing the cesarean section, after delivery of the placenta, you can put the IUCD into the uterine cavity and put the stitch and come out. That is one way. Second, if you are going to deliver the vaginal delivery, after the delivery of the baby, after the delivery of the placenta, you can put the IUCD, then you can put the episiotomy stitch. Or if the mother delivered, you didn't put, but up to 48 hours, you can put the IUCD. After 48 hours, you can't put. You have to wait until 6 weeks. Do you understand? So there are advantage of PPIUCD. What are the advantage? One is you are not letting the patient to go home, right? So patient might say, doctor, I will come and put the IUCD, right? Doctor, I will come and put the IUCD later. But what will happen when she come back? She will become pregnant. Mostly she will come with 2 lines. Doctor, 2 lines coming, what to do? So mostly this less pregnancy interval is due to failed contraception. So if you leave the mother to go home, then mostly she will not come. So you can put it and send her home. That is a good idea. Do you understand? So that is the reason we introduced the PPIOCD. But there are problems. What are the problems? So you can't put some instances, like if the mother has bleeding, continuous postpartum hemorrhage, right? Continuous postpartum hemorrhage, you can't put it. Right? You can't put it. If it is a continuous postpartum hemorrhage, you can't put it. So if it is an infection, chorioamnionitis, you can't put it. Right? So there are contraindication for the PPIUCD. There are contraindication for the PPIUCD. Okay, right. So here they are asking following are true or false regarding the intrauterine device. It is a long-term reversible contraceptive method. LARC, true or false?
True.
What is LARC? Long-term reversible contraception. Or long-acting reversible contraception. LARC. What is that? So the definition of LARC is if you are introducing or using this contraceptive device, right, less than 1 time in a month. That is LARC. Do you understand what I'm telling? If it is an OCP, you are using every day, more than 1 time in a month. But if it is a DMPA, you are injecting every 3 months, so less than 1 time in a month. If it is an IUCD, once you put, you have to put again after 10 years, less than 1 time in a month. So if you are using a contraceptive method less than 1 time in a month, that is called LARC. So it is good because if somebody is taking daily IUCD method or daily contraceptive method like OCP with the workload, they might forget. So then she might become pregnant. So failure rate is high. But if it is a LARC, put and forget. She put the IUCD and forget it. For 10 years, she don't need to worry anything. She can look after her children. She can look after her husband. She can look after the household working. No problem at all. Do you understand? So the LARC has a lot of advantages. So, what are the LARC methods available? One is DMPA, IUCD, Implanon, Jadel, right? LNG-IUS. Those are less frequent, more than one month. You are injecting more than 1 month, right? So if it is an OCP, progesterone-only pill, you have condom every day. It is not LARC. If you put the condom, can you keep for 1 or 2 years? So then it is not a LARC. Every day you have to use it. Got it? Right. So for postpartum IUCD is a LARC, you are true. Should be removed after 5 years of insertion. IUCD, what is the duration? 10 years. Right? Not 5 years. It's 10 years. It's false. Can be inserted at the time of cesarean section. Yeah. Can be inserted at the time of cesarean section. True or false?
True.
Yeah, that's true. IUCD, you can keep for 10 years. You can insert at the cesarean section. True. Chorioamnionitis is a contraindication.
True.
True. Chorioamnionitis and continuous postpartum hemorrhage or bleeding, it's contraindicated. Kelly's forceps are used for the insertion. What is Kelly's forceps? So actually, don't worry, I will show you these instruments when you are going for the Viva exams, right? So this time we had a instrument class. Next time also I will show those instruments. You don't need to worry. Kelly's forceps is a long forceps because after the delivery, the uterus is larger. So if you use your routine IUCD inserter, your routine IUCD inserter is designed for the interval one. So small uterus. So it will go to a pelvis only, but after the delivery, uterus will be at the level of umbilicus. So if you insert the IUCD with your normal inserter, what will happen? You can't insert the IUCD into the fundus because fundus is at the level of umbilicus. So you will insert in the lower part of the uterus. So then what will happen? With the time it will come out, expulsion. So if you want to insert the IUCD after the delivery, you have to insert in deeper. So then you need to have an instrument which is longer. That is your Kelly's forceps. That's true. So Kelly's forceps are used for insertion too. So answer for question number 9, true, false, true, true, true. Can you put Jadel or Implanon soon after the delivery? Yeah, we can put soon after the delivery. It's not a problem. Right. Regarding the shoulder dystocia, question number 10, regarding the shoulder dystocia, causes postpartum hemorrhage? Yes, because it's a large baby. Risk of perineal tear is high, so it can cause postpartum hemorrhage. That's true. Managed by Macrobot position? Yeah, that's true. If it is a shoulder dystocia, the first line management is Macrobot position and suprapubic pressure. If fail, then we are going for a second line maneuvers. That is your internal maneuver. Robbins maneuver, wood screw maneuver, reverse boot screw maneuver. Right? So, and posterior arm delivery. If second line fail, then we have to go for a third line maneuvers. What are those third line maneuvers? Those are symphysiotomy, clidotomy, and Savanelli maneuver. I'm not going to tell each and every maneuvers and how to do and things in this question, but in another question I will teach you, right? But you should know how to do all these maneuvers, because this time when the students are going for a Viva, they ask how to do. But my students could able to answer those questions because I taught them. They know how to do these maneuvers. Especially when you are coming to the Viva class, I will teach you with the dummy and all. We can do that, no problem, right? So regarding shoulder dystocia, causes postpartum hemorrhage true, managed by the Macrobot position true. Pinard maneuver is useful. That's false. Pinard maneuver we are using for the breech delivery, right? Not for the shoulder dystocia. It's false. Causes Earp palsy, yes, because when you are pulling the baby's head like this, the cervical spine will get stretched and the cervical nerves, this spinal nerve will get damaged, and which can cause Earp palsy. Yeah, that's true. It is a complication of fetal growth restriction. It's false. When the baby is larger only, it will get struck, not the small baby. Right? So, complication of macrostomia and diabetes, not for the IUGR. It's false. So, answer for question number 10, true, true, false, true, false. Right. Now, we are going to move to the SBA, first question. So, please try to understand when I am doing the question, right? Don't concentrate the answers. Right? Answers is not your aim. So you need to identify how I am dividing the question, how I am identifying the problem, how I am using the background knowledge, and how I am identifying the best answer, that is single best. Because more than one answers are correct, but you have to select the best answer among the answers. Do you understand? You need to select the best answer, right? So, okay, we will go on it. Question number 11, a 30-year-old mother in a second pregnancy with 37 weeks of period of gestation in second stage of labor for 2 hours and 30 minutes. What is the next step of management? Tell me the answer, then I will tell you how to identify.
Arrange for delivery.
Right, okay.
For wrong
answer is correct. I will tell you why it is. Now, what are the information you need to gather from this question? First one, a 30-year-old. That is one, because the maternal age has a lot of impact on our management. 30 years. Second pregnancy. So she's multipara. She delivered previously. Right? Second pregnancy. 30 weeks. It means it's not the preterm. It's a term pregnancy. See, each and every word, because if it is a preterm delivery, you can't put vacuum. If it is a term delivery, you can put vacuum as well. So it's a term baby. So the summary is 30 years, second pregnancy, term baby is in labor. So even though they are telling in a paragraph, you need to have an idea. Okay, 30 years, second pregnancy, term baby in labor. she is in second stage of labor for 2 hours and 30 minutes. So the second pregnancy, second stage of labor, 2 hours and 30 minutes. Is it okay? Or are you happy or not happy? Here? Yeah, it is prolonged because for second pregnancy, second stage labor should be 1 hour. So this is prolonged second stage. If it is a prolonged second stage, can you wait further? No. So then what you want to do, you want to take the baby out. You want to take the baby out. So what are the possibility you can take the baby out? Either you can do cesarean section and take the baby out, or you can do the assisted vaginal delivery. Means you put the instrument and take the baby out. So if you want to put the instrument, you need to look for any contraindication for the instrumental delivery. Here, have they mentioned anything about the instrumental delivery? Contraindication? No. So waiting for the spontaneous delivery. What do you think? Can you wait further? No. Arrange for forceps delivery? We can arrange the instrumental delivery. Emergency cesarean section? Yeah, that is also correct. So there are 2 correct answers. The next answer, do artificial rupture of membrane and start syntosine. Already it's prolonged. We are not going to start the synto and wait further, right? And give IM pethidine. Oh my God, you can't give the pethidine right now because once you give the pethidine, once the baby delivers, what will happen? Baby will develop respiratory distress. So obviously, rest of the 3 answers are wrong. But I know either forceps delivery or emergency cesarean section could be correct answer. Among this, which one is more suitable? So you have now you are thinking in a rational way. This is a second pregnancy. She delivered vaginally previously. They didn't mention any other contraindication for the instrumental delivery. It's a term baby. So rather than cutting the mother, you can go for instrumental delivery. So you should know why you are selecting that answer, why you are rejecting the another stem. So just memorizing the answer is not going to work at all. Please don't memorize the answer. This is what I'm always telling to my students. Please don't memorize. Just think, what is the principle I'm using? How I am coming to the answer? Why I am selecting this answer? Why I am rejecting rest of the answers? Do you understand? Okay, Anjali, right? So we should know why we are rejecting the rest of the answers. Okay, right. So answer for question number 11 is A. So once again, IM pethidine cause respiratory distress of the baby. Yeah, of course. Because this pethidine is a respiratory depression. So if you give the pethidine just before the delivery, it can cross the placenta and it can cause respiratory distress to the baby. That's why they are telling. So if you give the pethidine, at least you need 4 hours time for elimination of pethidine action from the baby. Okay, right. Question number 12. A 24-year-old primey, 34 weeks, presented with generalized itching without rash, more common on palm and sole, elevated liver enzyme. Viral studies for hepatitis normal. Right? Viral study for hepatitis is normal. She is otherwise uncomplicated. Most appropriate management. Yeah, tell me the most appropriate management.
Symptomatic obstetric ursodeoxycholic acid. Answer C.
Is 5 p.m. theory class start after the, yeah, of course, after the paper class, we'll start the theory class, right? Yeah, answer C. Okay, now, right, I agree with your answer. First of all, we will find the important words in this question. 24 years, yeah, that is important one. Priming, yeah, priming also important because priming has risk for the obstetric cholestasis. Priming. 34 weeks, it's preterm, right? So if it is 38 weeks, you can deliver the baby. You don't need to give any treatment, just deliver the baby. If it is 34 weeks, you can't deliver the baby because it's preterm. Do you understand the importance of knowing the period of gestation? It's a preterm, right? And she's presented with generalized itching without rash, more common in palm and sole, with elevated liver enzyme. So this is the characteristic feature of obstetric cholestasis. This is the characteristic feature of obstetric cholestasis. Because of the pregnancy, the bile is accumulating, cholestasis occur. So which can cause generalized itching, more common in palm and sole, usually not having rash. Also, it will involve with the liver damage, which cause elevated liver enzyme. So because of the obstetric cholestasis, there are two kinds of problem. One is the liver damage can cause liver failure to the mother. Second one, bile acid not coming to the alimentary canal, so fat soluble vitamin will not be absorbed. So vitamin K deficiency, which can lead postpartum hemorrhage to the mother. Right? So that's why what we do, we are giving water soluble vitamin since 36 weeks to the mother to prevent the postpartum hemorrhage. Do you understand? So which can cause liver failure as well as the bleeding disorders and fat soluble vitamin deficiency due to the mother. What will happen to the baby? And also mother will develop itching and symptomatic status. And what will happen to the baby? This bile acid, when the bile acid is not coming to the alimentary canal, what will happen? That will spill into the maternal bloodstream. When it is spilled into the bloodstream, what will happen? The bile acid concentration in the maternal bloodstream will increase. When it is increasing, it will cross the placenta and enter into the fetal circulation. That bile acid which is in the fetal circulation will cause fetal heart block. Right? So that heart block can kill the baby. So to kill the baby, at least the maternal threshold for the bile acid level should be 40 millimole. If it is less than 40 millimole, risk of fetal death is less. If it is more than 40 millimole, risk of fetal death is high. So if it is an obstetric cholestasis, what you can do? You can treat the patient with ursodeoxycholic acid for the itching. And what is the definitive management for the obstetric cholestasis? Delivery of the baby. But if it is preterm, you can't deliver. But what you have to do, you have to monitor whether it's dangerous to the mother or dangerous to the baby. When it is dangerous to the mother, we are not thinking about the preterm, we deliver the baby. So what we have to do, what are the dangerous things can happen to the baby? It can cause obstetric heart block because of the bile acid. So you have to monitor the bile acid. When the bile acid reaches to 40, deliver the baby because it is not good for the baby. Same time, you have to monitor the liver enzyme. When the liver enzyme is very high and liver failure features and mother is symptomatic liver failure, deliver the baby to save the mother. Don't think about the preterm. So if it is an obstetric cholestasis, we don't deliver the baby because it's preterm. We are monitoring the mother with the bile acid and liver enzyme, right? And if the mother or baby develop distress, you deliver even it is preterm. If no one is distressed, just treat the symptoms with ursodeoxycholic acid and deliver the baby by 37 to 38 weeks. Because by 37 to 38 weeks, already baby matured. Then no point in keeping this pregnancy, isn't it? You achieve the target. What are you going to achieve by keeping the pregnancy until 40 weeks? No, nothing. Only complications. So you deliver the baby. Do you understand? Are you all following? So here they are telling, so this patient is having generalized itching. Yeah, of course, we agree, right? So it's an obstetric cholestasis and liver enzymes are elevated, but you don't need to deliver as it is 34 weeks. Just give the ursodeoxycholic acid. Answer is C. Question number 13. A 65-year-old female presented to the gyn clinic with lump at vulva and stress urinary incontinence. On examination, she was found to have third-degree UV prolapse with moderate cystocele and a large decubitus ulcers. What is the initial management to this patient? What is the answer?
Answer D, vaginal hysterectomy and anterior repair.
Okay, right. So I agree with your answer, but that is not the correct answer, right? Because that is what I told you, because there might be more than one correct answer, but you need to select the best answer and you have to concentrate each and every word, right? So I'm reading the question in a different way. 65 years, she's postmenopausal lady. That is the information I gathered. With lump at vulva and urinary incontinence. So on examination, third degree UV prolapse with moderate cystocele and large decubitus ulcer. What you understand by decubitus ulcer? When the vagina is hanging on the vascular pedicle, the blood will accumulate in the cervix. So like a varicose vein. So because of the blood accumulation, there will be an ulcer because of the blood accumulation. So when you have an ulcer into the cervix, you can't operate over the ulcer. You need to heal the ulcer first. Because if there is an ulcer, you can't make the incision, then that infection might enter into the bloodstream and it can cause sepsis and patient will die. So you can't do the surgery. Obviously, as it is a third-degree UV prolapse, there is no option. You need to go for a surgical management. Vaginal hysterectomy and repair is the management. There is no question. But can you do the vaginal hysterectomy right now? No, because she's having ulcer. When she's having ulcer, you can't do surgery. What you have to do, you have to heal the ulcer. How can you heal the ulcer? So you should know what is the reason for the ulcer, because of the vascular congestion. So why vascular congestion? When the uterus comes down, the veins are getting compressed, but artery continue to feed. So blood is not going back. So that's why it's accumulating. So then what you want to do, you want to replace the uterus temporarily into the normal position. So when you replace to the normal position, that venous congestion will remove. So then blood will not be accumulated, then wound will heal. So how can you keep the uterus temporarily into the normal position? How?
Ring pessary.
Ring pessary. You can keep the ring pessary and wound will heal. So read the question carefully. What is the initial management? They didn't ask what is the definitive management. What is the definitive management? What is the definitive? Very good. Vaginal hysterectomy. Vaginal hysterectomy is the definitive management. But here they are asking about what is the initial management. Do you understand how the question and how you have to answer? So that's why I told you, you have to properly understand the question and use your background knowledge, identify the real problem, use your background knowledge, think rationally, then only you have to answer. Right? So if it is a third-degree UV prolapse, quickly you can't jump and answer like vaginal hysterectomy and repair. Yeah, of course, the answer is correct, but that is not the initial management. Do you understand? Okay, great. So answer is ring pessary, B. Question number 14, a G2P1 at 40 weeks has cervical dilatation 5 cm at 8 a.m., 7 cm at 12 p.m. She is getting 4 contraction in 10 minutes. The station of the head is 2 cm above the ischial spine with moderate caput and grade 3 molding. Membranes are absent. The sacrum is flat and ischial spine are prominent. Estimated fetal weight is 4 kilo by ultrasound scan 5 days before. Fetal heart rate is 140. Previously, she had uncomplicated vaginal delivery of 3 kilo baby. What is the most appropriate management? Yeah, what is the most?
Lower cesarean section, high cavity, because of high cavity obstructed labor.
Okay, good. Okay, yeah. The definition of the diagnosis is CPD, cephalopelvic disproportion. Right, okay. I'm just reading the question. This is the second pregnancy with previous one uncomplicated vaginal delivery of 3 kilo baby. Now she's 40 weeks. She got admitted to the labor room, right, with 5 centimeter dilated at 8 a.m. and 7 centimeter at 12 a.m. So it means in 4 hours time, her progression is only 2 centimeter. But if it is active stage of labor, more than 4 centimeter, what is your expectation? What is your expected progression? 1 centimeter per hour. So if it is 5 centimeter at 8 a.m., 9 a.m. it should be 6, 10 a.m. 7, 11 a.m. 8, and 12 p.m. it should be 9 centimeter. But actually it is 7 centimeter. So what do you think? Is it adequate? Is it adequate? No. So it is lack of progression. Progression is not adequate. So if the progression is not adequate, what could be the reason? Where could be the reason? So the reason could be at power, passenger, and passage. Power, passenger, and passage. What do you think about the power? So what is your expected uterine contraction in active labor? 3 to 5 contraction in 10 minutes. If somebody has 3 to 5 contraction in 10 minutes, the power is okay. What about her contraction? How many contraction? 4 contraction in 10 minutes. Is it adequate? Yes. So this lack of progression is not due to power. Are you all happy with that? Lack of progression is not due to power. So it could be problem with the passenger, maybe a malpresentation, but it's a cephalic presentation. The baby's head is 2 centimeters above the ischial spine. Yeah, right. So they didn't mention anything other than the baby's position. So third problem could be in the passage, inadequate passage. So if it is inadequate passage, you need to look for any other features which is suggestive of inadequate passage. So if the passage is not adequate, what are the features? One is lack of progression. Second one is caput. Third one is severe molding. Stage grade 3 means severe molding, fetal distress, right? So, and you can assess the passage. How is the passage? Whether the ischial spine are downcline or incline or downward, right? Whether your pelvic inlet is adequate, right? So here they have mentioned the membrane, the baby's head is 2 centimeters above the ischial spine. It means if the baby's head is at the level of ischial spine, the station is 0. If the baby's head is at the level of ischial spine, station is 0. If it is above the ischial spine, means station is minus. So here they have mentioned 2 centimeters above the ischial spine. So what is the station of the presentation? Station is minus 2. So when you are saying the baby's head is engaged, when the station is minus 1 only, we can say the head is engaged. This is minus 2. It means head is not engaged. Now all the features suggestive this passage is not adequate. Head is still not engaged even after 7 centimeter dilated. The labor is getting delayed. Caput is there. Molding is there. Contraction is adequate. But luckily baby is having good heart rate. And estimated fetal weight is 4 kilo. But she delivered 3 kilo earlier. That is okay. Small baby could came. But is a large baby couldn't come. The pelvis is not adequate. And they are mentioning that also. Sacrum is flat and ischial spine are prominent. When the ischial spines are prominent and flat sacrum, obviously it will not allow the baby to come out. So it is CPD. If it is a CPD, can you go for a vaginal delivery? Is it possible to go for a vaginal delivery? No, it's contraindicated. You have to go for a cesarean section. So answer is E. So you should know each and every word how we are interpreting and coming to the answer. Right. Question number 15. A 30-year-old second para who has type 2 diabetes mellitus attended to the antenatal clinic at POA of 11 weeks. She is not on regular treatment and HbA1c is 7.8. She is worried about the possibility of fetal anomaly. Which one of the following is reliable to exclude the anomaly? So obviously the initial part is not really relevant to this question. Only they are correlating if she is a diabetic patient with poorly controlled, which can cause fetal anomaly. So this is HbA1c is more than 6.5. It's uncontrolled, right? So the risk of fetal anomaly is a bit high. So this baby might develop fetal heart rate abnormalities, right? So fetal heart rate abnormalities. So sorry, cardiac anomalies. So you want to identify whether the baby is having some kind of fetal anomaly. How do you identify? What is the best way available to identify the fetal anomaly? What is the best? Yeah, ultrasound scan. When you can do the ultrasound scan, specially to identify the abnormality. Very good. At 20 weeks, from 18 to 22 weeks is the ideal time for the fetal anomaly. 18 to 22 weeks is the ideal time for the fetal anomaly. Right? Okay. So there are questions. Sir, if there was no molding and C-section was minus, or station was -1, can say vacuum delivery if there was an option. No, you can't do the vacuum delivery right now because it's 7 centimeter dilated. You can't do the vacuum delivery. You can wait for some time, right? You can wait whether its labor is progressing or not. You can't do the vacuum delivery, right? The molding is mild or moderate molding is normal. You don't need to worry. But if it is a severe molding, grade 3 molding, it's severe. It's CPD, right? So question number 15 answer is A, right? So ultrasound scanning for structural abnormality at 20 weeks. Right. So question number 16, a 23-year-old unmarried woman asked for the emergency contraception 4 days after the unprotected sexual intercourse. She is in a stable relationship. What is the best option? What is the best option? Huh?
Answer C.
Oral ethanyl estradiol. Actually, ethanyl estradiol is not a emergency contraception. Okay, so this is also very nice question. You need to understand the question, right? So here, read this question: 23-year-old unmarried. So providing contraception, it's not depend on the marital state, right? So it is depend on the sexual relationship. So she might be unmarried or married, doesn't matter. She is on sexual relationship, stable sexual relationship. So she's requesting for a contraception for unprotected sexual intercourse, which has happened 3 days ago, 4 days ago. So there are 3 methods available as an emergency contraception. One is levonorgestrel emergency contraception. Second one is juliprostate acetate. Third one is IUCD, copper IUCD. Right? This levonorgestrel oral emergency contraception is effective up to 72 hours. If you give this levonorgestrel after 72 hours, after 3 days, it's not effective. So for this one had a unprotected sexual intercourse 4 days ago. So then levonorgestrel is not an option. So either you can go for a juliprostate acetate or you can go for a copper IUCD. Because juliprostate acetate and copper IUCD is effective up to 120 hours, 5 days. So you can use those things up to 120 hours. So here, so if you have both answers, juliprostate acetate and copper IUCD, which one is the best answer for this patient? What do you think?
Acetate.
Juliprostate acetate. Why?
Because it's nullipara.
Nullipara, it's not a problem at all for IUCD. Only we are worrying unmarried girl, we don't put the IUCD because you are not supposed to break the hymen. But in this patient, even though she's unmarried, you don't need to worry about the hymen because she's sexually active. Right? So here you don't need to worry about the nulliparity. But what is the major point you need to identify? There is a word called she is in stable relationship. It means giving juliprostate acetate right now, it's a temporary solution. Tomorrow also she will have unprotected sexual life. Day after tomorrow, yes. Next month, yes. After that, yes. She is going to continue this. So giving emergency only, it's not an option. She needs some kind of contraception. So juliprostate is only single option. But if you give IUCD, obviously it will act as an emergency contraception and also it will last for some time until she ready to become pregnant. It will act as a normal contraception as well. So she need IUCD, not the juliprostate. Why? She's in stable relationship. She needed another contraception as well. You can't use the emergency contraception frequently, like juliprostate or like prostanol. So the best answer for her is actually IUCD, right? She is in stable relationship. See, this is what I'm telling. Please, just see each and every word. That is very important. And each and every word, that is very important. Okay. We will inform to the theory students. We will start in 10 minutes. It's less. Okay. Question number 17. A 34-year-old woman attended for the booking in her third pregnancy. She had a cesarean section in her first pregnancy 4 years ago, and she had a successful vaginal delivery in second pregnancy 2 years ago. Her BMI is 26. What is the best prediction for the successful VBAC? So if somebody have previous cesarean section, you can predict whether she has a chance to have vaginal delivery. Normally, vaginal delivery following cesarean section successful rate is around 75%. VBAC successfulness around 75%, right? But there are some predictions. There are some predictive factors which can increase the successfulness. Okay. So what is the most important successful factor or single most predictive factor for the vaginal delivery is previous vaginal delivery. If somebody has previous vaginal delivery, either before the cesarean section or after the cesarean section, doesn't matter. If somebody has a history of vaginal delivery, the successfulness for the VBAC is high. The successfulness is almost 90%. If no vaginal delivery history, 75. With vaginal delivery, successfulness, VBAC successfulness is 90%. So here they are asking, what is the best predictor for successful VBAC is previous vaginal delivery? Answer C. Question number 18. A 23-year-old primigravida presented at 36 weeks of gestation with continuous abdominal pain and mild vaginal bleeding. On examination, she is moderately pale. Her blood pressure is 120/70 and blood group is O negative. Uterus was tender. CTG tachycardia. What is the most appropriate management option?
Expedite the delivery, placental abduction, fetal.
Yeah, very good. So it is a placental abruption. So because she's having continuous abdominal pain, pervaginal bleeding, tender uterus. So this is a placental abruption. When a mother admitted with placental abruption, you have to check two factors. One, first you need to check whether mother is okay, maternal distress. Second, you need to check whether baby is okay. Right? Because always we are giving the priority to the mother first. If the mother is unstable, don't think about the fetal condition. Even baby died, doesn't matter, do section and take the baby out. Right? Take the baby out. Baby, whether baby is doing good or not good, baby is in distress, immediately take the baby out because baby will die. If baby also okay, mother also okay, then you don't need to be hurried to deliver the baby. You can stabilize and you can check whether you want to deliver or you can give the DEXA. You can wait for some time. You can decide about that. Here, obviously, this patient is placental abruption. Mother is 120, blood pressure is 120/70. Yeah, of course, she's stable. Mother is not in danger. But baby is having tachycardia. It means baby is having hypoxia. So if the baby is having hypoxia, is it good to keep the baby inside the uterus? Because placenta separated. Blood supply to the placenta affected. So baby is not getting enough blood supply. So baby might get hypoxia. Baby might die. So is it safe to keep the baby inside the uterus? No. You need to expedite the delivery to save the baby. So answer is D. Question number 19. A 22-year-old woman presented to the early pregnancy unit with mild left iliac fossa pain. On examination, she's normal. She has positive urine test and serum beta HCG is 700. Vaginal examination reported anteverted uterus with 2 mm cystic area centrally located in the endometrium. Both ovaries are normal. There is no adnexial mass. What is the most appropriate management?
Pregnancy unknown location, repeat HCG in 48 hours.
Okay. Before we discuss this question, there was a doubt from students. He's asking, sir, don't you have to confirm abruption with ultrasound scan first? Please keep it in your mind. Ultrasound, so placental abruption is a clinical diagnosis. You can't diagnose the placental abruption with ultrasound scan. Clinically only we diagnose. We don't need to do ultrasound scan to diagnose the placental abruption. Clinical. Continuous abdominal pain, pervaginal bleeding, tender, woody, hard uterus abruption. You don't need to do scan. Right? Keep it in your mind. Ultrasound scan is not necessary to diagnose. Very good. So you should know why we are rejecting that answer. Good. Okay. We'll come to question number 19. A 22-year-old lady presented with left iliac fossa pain and urine HCG positive, but when they do the scan, inside the uterine cavity, there is a fluid-filled cavity that is a pseudosac. Because if it is a pregnancy, usually pregnancy will be in the decidua, not in the cavity. Right? So that is called intradecidual sign. That is called intradecidual sign. Right? So there is so okay, I'll teach you what is this decidua and blah blah things. Okay. Now you can see this is the uterus. Okay. This is your endometrial cavity. So during the pregnancy, endometrium will be thickened. Thickened endometrium called decidua. So when the baby is coming, actually baby can't implant inside the cavity here. Because in the cavity, how the baby can implant? What will happen? Baby will enter into the decidua. So usually baby will be in the decidua, in the endometrium, not in the cavity. So if you can see a fluid-filled cavity into the decidua, that is baby. That is called intradecidual sign. So when you see if the baby is into the decidua, you can say it's an intrauterine pregnancy. But when there is a fluid collection in the cavity, central uterine cavity, means it is not the baby, it's just fluid collection. So you can't misinterpret this one as a baby. This is a pseudosac. So that is what they have mentioned. There is a fluid collection in the uterine cavity, so that is a pseudosac. So that is not the pregnancy, but pregnancy is not there, right? Pregnancy is not there, right? So intrauterine pregnancy is not there, extrauterine pregnancy also not there. Beta HCG level is 700. So what are we going to do? We are not going to. So what is the diagnosis? This is called pregnancy of unknown location. We don't know where is the pregnancy. It could be early pregnancy, it could be ectopic pregnancy, it could be miscarriage. So then what we have to do, we have to repeat the beta HCG, right? We have to repeat the beta HCG in 48 hours. When you are repeating the beta HCG, if it is doubling, it means baby is in the uterine cavity. If it is reducing, it means baby is miscarrying. If it is increased, but increasement is suboptimal, then it could be an ectopic pregnancy. So you can say whether it's ectopic or intrauterine or miscarriage by repeating the beta HCG in 48 hours. So answer is C, serum beta HCG measurement in 48 hours. Question number 20. A 16-year-old girl presented with primary amenorrhea, secondary sexual characteristics are present. Abdominal examination reveals suprapubic mass. What is the next step of management? What is the answer?
Karyotype.
So will the exam paper series class start? Once the exam announced, we will do the exam paper series. Yeah. What is the answer? Okay, what is the diagnosis? This one. Here, 16-year-old girl, primary amenorrhea, secondary sexual characteristic, abdominal examination reveals suprapubic mass. Above the pubic symphysis, there is a mass. What could be the reason for this? Delayed puberty could be possible, but then how can you explain the suprapubic mass? Yeah, very good. This is an outflow tract obstruction. Somewhere is obstructed. Maybe transverse vaginal septum, maybe a transverse cervical septum or transverse uterine septum. Something is obstructing. So highly it is a transverse uterine septum. That's why the blood is accumulating inside the uterus and uterus is enlarging. That's why you could feel a mass above the pubic symphysis. So there is a septum inside the uterine cavity. So if you want to see the septum, the soft tissue, what is the diagnosis? What is the diagnostic modality will help you to find out the soft tissue?
MRI.
MRI. Yes. So what is the investigation she need? MRI. So the MRI will help you to find out whether there is a septum or not. So answer is A. Perform karyotyping because first of all we need to exclude whether she is having uterus or something. So then perform FSH actually no need because she is having secondary sexual characteristics. So perform diagnostic laparoscopy. Laparoscopy will not help you to find out inside the uterine cavity. And reassure and review after you can't because she's 16 years already. So then you have to investigate. So answer is A. I think you all utilize this free class. Is it? What is the definition of primary amenorrhea? Yeah, there are two definitions. One is absence of menstruation after 14 years without secondary sexual characteristic, or absence of menstruation after 16 years with secondary sexual characteristic. Right? Ultrasounds can indicate for the. So if they mention Emma, oh, it's going very fast. Imperforated hymen presented with suprapubic mass. No, usually they might, rather than the suprapubic mass, they might present in the vaginal bulging, imperforated hymen. If they mention ultrasound scan, still the MRI is the answer? No. Ultrasound scan will be the answer because MRI is a second line investigation. First, you just do the ultrasound scan. And in the ultrasound scan, if there is a hematomatron, then we know the blood is collecting inside the uterine cavity. Then only we have to go for a MRI. Okay. Right, good. Okay, so I will inform you the next date, next paper class. So please keep studying the obs and gynae, right? So don't leave because they might suddenly announce the exam date, right? So please don't stop studying. Continue to study. I will give the pre-screen access as well, so that also will help you. I also will help by doing this kind of free classes. So my ultimate target is to keep your pass rate more than 90%. Okay, so I will do extra work. You also have to do the extra work. No, this is for you. Okay, so can you start the course for the missed topic like obstetric cholestasis? Yeah, of course. We'll think about that. Yeah, sure. Okay, actually, I supposed to start the theory class restreaming today 5 p.m. We are a bit delay because of some technical issue. Yeah, Janit, welcome. How are you? Right. So, okay, right. So we will. Yeah, I'm good. So we will meet soon. Maybe next week we'll do the next class. Okay. Bye.
Bye, sir. Thank you, sir.